Hi, my name's Professor Tom Wainwright. I'm a physiotherapist from the United Kingdom. Today I'm going to talk to you about enhanced recovery in orthopaedics and specifically hip and knee replacement. I've worked in enhanced recovery for over 15 years as a clinician, as a manager and more latterly as an academic and researcher. I'm passionate about enhanced recovery and I'm going to share some thoughts with you around hip and knee replacement and enhanced recovery now. So what are we going to cover? Well, very briefly, we're going to cover the background components and history. It's important that we have this in the forefront of our mind. We're then going to talk about enhanced recovery in hip and knee replacement. We're going to touch on the ERAS Society guidelines for hip and knee replacement, and then talk about the future challenges, such as how do we make more patients a day case or an outpatient hip or knee replacement, and also what happens after discharge. Once we've reduced length of stay as far as we can, how can we think about returning patients to their normal lives as quickly as possible? So this is a slide and a statement that you'll have seen many times before, but it emphasises that enhanced recovery is a multimodal approach that seeks to reduce the surgical stress response and allowing patients to recover quickly so that they can go home quicker. It's about better care, which then equates to faster care. And this graph will also be familiar to many of you. The red line shows the effect on functional capacity of the surgical infarct. Functional capacity is reduced in the days after surgery and then slowly recovers. But with enhanced recovery, we reduce that surgical infarct. We reduce that surgical stress response through a multimodal intervention based around a multimodal approach to pain relief that is opioid sparing, early exercise and mobilisation, and early return to nutrition and drinking. And as we think about this underlying components of enhanced recovery, I think we should also remind ourselves of the three questions that Prof Kellett asked us and still asks of all people involved in enhanced recovery today. Can every operation be ambulatory? Why is the patient in hospital today? And what is it that we cannot control? And as we move on and look more about the components of enhanced recovery, we need to emphasise this multimodal but multidisciplinary approach. Enhanced recovery is something that is delivered by the team: nurses, physiotherapists, anaesthetists, surgeons, managers, healthcare assistants, support services. It's a team effort due to its multimodal nature. And it's the aggregation of these optimised elements that allows patients to recover quicker, and we get this reduced morbidity and quicker achievement of discharge criteria. And this is underpinned at the preoperative stage by optimisation of things such as anemia, preoperative education so that patients understand what's going to happen to them in surgery and their expectations are managed. Around the surgical event, it's typified by minimally invasive or techniques in surgery that don't induce trauma, and also a regional approach to anaesthesia, typically, but a multimodal approach that is opioid sparing to pain relief and anaesthesia. Early ambulation or early mobilisation so that the patient stands and walks quickly after their surgery. And then, as I mentioned before, early return to dressing, normal activities and eating and drinking. So we've come a long way over the last 15 years. This is data from my hospital where I was manager back in 2007. We were one of the first hospitals in the United Kingdom to implement enhanced recovery. And overnight we went from 8 days down to 4 days. And what's important here is that it was unselected patients. It was all patients. And in the second paper referenced at the bottom, we found that actually enhanced recovery made the biggest difference to our older patients and our patients that had a higher ASA and had more comorbidities and took more medications. A really important point that enhanced recovery is for all patients. And as the last 10 or 15 years have developed, lots of literature and publications have been done on the topics of fast track and enhanced recovery. in hip and knee replacement. And we can summarise that enhanced recovery has been hugely successful at improving outcomes. Length of stay has reduced, and now typically it can be in day case for some patients, but 1 to 2 days for most patients in centres that have fully implemented enhanced recovery. Readmissions are reduced where they were already low, or stayed the same where they couldn't be further improved. Complications have also reduced or stayed the same, but crucially for both those things, they've not increased. Data from Mike Reed's group in Northumbria has shown that mortality, although it's a small number in hip and knee replacements, that has also been reduced by enhanced recovery. Patient-reported outcome measures and patient experience measures have been shown to improve. And there's been economic and operational efficiencies proven for the in-hospital stay for our patients. And these findings are summarised from work from the Danish Collaborative, where they've got a large number of patients from a number of different hospitals contributing to this prospective study on enhanced recovery. And you can see the graph on one side showing a gradual reduction in length of stay over a 10-year period, and readmissions in their setting about constant at around 8% at 90 days. And within that paper, they've identified the optimisation of certain elements around those readmissions that can be further improved in the future. So what is the detail of these pathways? Well, in the Enhanced Recovery textbook, we produced this schematic diagram, familiar to many of you, I'm sure, that has been reproduced across the surgical specialties. And a couple of years ago, we published the ERAS Society Hip and Knee Recommendations. I was part of this guideline group in what was a massive task to try and understand the massive amount of literature in this area. What was difficult is that we didn't have specific studies for each of the ERAS components in RCTs in enhanced recovery, completed in enhanced recovery pathways. This meant that the literature was heterogeneous. When we looked at one component, it had been used with different components compared to another study. There was also different outcome measures and different time points of those outcome measures. However, what we were able to produce was a starting point. For those centres starting to take part in enhanced recovery, it's a good starting point from which to develop. For those centres that are advanced in enhanced recovery, it poses us the questions of where we need to research in the future and improve things. However, I should point out that in the accompanying commentary from Henrik Kellett and Stavros, they made the very important point that we should concentrate particularly on the active components in hip and knee replacement. They made the case that many of the care elements that are familiar across all the ERAS protocols are actually principles now of modern day surgery. They highlighted 3 active components that are really important for hip and knee replacement. The first one is a standardised approach within your hospital or setting to anaesthesia and analgesia. This should be multimodal and opioid sparing and is typically the use of a regional anaesthetic technique. However, the specific recipe or method of this differs between hospitals. And if we look at the literature, day case arthroplasty is achievable with slightly different combinations of these drugs. However, the common theme is in the hospitals and in these exemplar centres, they have a standardised protocol which they do for every patient on every time. It has a clear escalation when pain is not controlled. And also the other team members understand this anaesthetic and analgesic combination. So they're not nursing patients on different regimes from one bed to the next. The second really important active component is blood management. Identifying patients before their operation that are anemic and can be optimised. Avoiding unnecessary blood loss during surgery and the use of tranexamic acid. Again, the specific details of how you give tranexamic acid to your patients can differ. The important thing is that you give it. And lastly, early mobilisation. This is vitally important. This is not only the first step to getting patients to achieve their discharge criteria so they can go home, but it also can be used as a really good analgesic intervention. Patients who mobilise their knee or hip joint early get less pain and achieve their discharge criteria quicker. Before moving on, I will make a comment about surgical technique. It's important here that we summarise that what's important is that there's no strong evidence to illustrate the isolated effect regarding length of stay of one specific surgical technique against another. In the paper on the screen, published some years ago, we looked at the role of minimally invasive surgery, and we found that it couldn't be shown on its own to make a difference. And the same can be said for different approaches to the hip or to the knee, and for the use of navigation and robotic. The surgeon choice around these is more around implant survivorship and avoiding malposition components. And of course, that's something that's happening in parallel to the enhanced recovery protocol that we're talking about when we're trying to achieve discharge criteria as quickly as possible. I've been fortunate over the last 15 years to work with a number of hospitals and across a number of different healthcare systems. And there's definitely characteristics of high-performing hip and knee units. They have dedicated departments where the hip and knee replacement patients are treated in isolation from trauma procedures or medical patients. This is really important. The departments all have optimised logistics. They have a written care plan with clear daily goals that the patient must achieve each day. The patients are clearly given an information before their operation about how long they are likely to stay in hospital. There's a multidisciplinary approach to preoperative planning. As I've said, regional anaesthetic and standardised techniques around analgesia and anaesthesia. The use of tranexamic acid, early mobilisation, and a well-defined discharge criteria. And patients can be discharged by any member of the team once they've been reached. They don't have to wait until the rounds on the next day when the surgeon comes round. And we know it works. If you've got increased compliance to ERAS components, you have a shorter length of stay and you have less complications. And the large Power 2 study from Spain helps us to articulate this. But getting increased compliance is difficult, especially if you have a large number of steps in the pathway. So we must also remember that enhanced recovery is a quality improvement intervention. What I mean by this is the guidelines and the evidence that we read in our clinical journals helps us to inform the clinical decisions. That's doing the right things. However, if we want good patient care, we need to do the right things in the right way for every patient. So that means we need process and system changes alongside the clinical changes. And the papers on the other side of the slide are some examples of when improvement has not gone so well, and also the reasons for why an improvement has gone well. And I urge you, if you're interested in this topic, to read those papers. So where does that leave us? Well, in an article written a couple years ago, we looked at the current status of enhanced recovery, which I've gone through already, and we looked at the future challenges. We still must ask ourselves, why is the patient still in hospital today, and what is it that we cannot control? We think we can learn more about the pre and post-op reduction of the inflammatory response, understand which patients are high inflammatory responders and which patients are low inflammatory responders, and understand that they may need slight alterations to their analgesic and anaesthetic in regard to this. Ongoing and persistent pain after knee replacement, for one example, is still a problem. If you look at the literature, around 20% of patients a year after surgery still have pain after a knee replacement. So there's optimization needed for our analgesic strategies. Anemia and transfusion thresholds can still be optimized. We must understand the feasibility of outpatient surgery for all patients. Or if it's not for all patients, how do we analyse risk and high-risk patients preoperatively so that we can plan for a slightly longer length of stay as compared to a day case surgery? And then we must also think about the type, timing and duration of physiotherapy for different groups of patients. We need to think post-discharge and how we can optimise functional recovery. Day case surgery or ambulatory surgery is increasingly making the headlines, especially as we exit the COVID pandemic. I'm highlighting this study from a few years ago from Denmark, where they took unselected patients in a socialised health system and found that they could safely discharge around 15% of patients on the day of surgery with no problems. This number is increasing, and we're seeing increasing examples specifically in the United States of increased day case surgery in ambulatory surgical centres. When we look at this, however, we must ensure that those patients are being discharged home and they're not having intensive support after they've gone home. Remember, it's first better and then faster. I published this paper last year looking at the rate of day case in the United Kingdom. In actual fact, although it's talked a lot about at conferences and within surgeons, at that time it was less than 1%. More interestingly was that even though enhanced recovery has been around in the United Kingdom for over 10 years, we had a national programme back in 2009 to 2011, average length of stay is still over 4 days, and 20% of patients still stay longer than 4 days. So even where we know about enhanced recovery and people think they've implemented, the outcomes would suggest otherwise. So as we move forward, we must think about this delicate balance between implementation of enhanced recovery and moving too fast to this more widespread implementation of the promising outpatient approach. We must remember that ERAS concept is based on a reduction of the undesirable pathophysiological responses to surgery in order to enhance recovery, meaning that we must first get better and then faster. And so really, if you're thinking about doing day case arthroplasty, you should have a well-implemented enhanced recovery program already at 1 to 2 days. Don't try and go from 4 days to day case, as we should be mindful we need to walk before we run. So what happens after discharge? For us, they're discharged from hospital, but for the patient, that's when the recovery really starts. And we need to think more broadly in our outcome measures. I've spoken a lot about length of stay, and that's where enhanced recovery looked at in its early days. But with hip and knee, with length of stay reducing, it's crucial that we look after discharge about how we can return patients to work, to social activities, to caring responsibilities, and their role in society. This is important, and there's a major need to think about rehabilitation strategies and the advice we give to patients after surgery. This is a schematic diagram, but it's based on what the current literature shows us. It shows us that surgery is fantastic in hip and knee replacement at reducing pain and improving patient-reported outcome measures and their perception of function. But actually in the short term, we get a reduction of muscle function, we get a reduction of activity, and we get a reduction of our activities of daily living. And if you look at meta-analysis data, 6 months after hip and knee replacement, patients are less active than they were before the operation, even though they would report that they're more active and that they're recovered. Data to support this has been shown in a Danish publication. They looked at the comparison between patient-reported outcome measures at 2 to 3 weeks after surgery and what the physical performance tests were of those patients. So they asked in a questionnaire the patient's ability to walk, go upstairs, go from sitting to standing, and they compared that with actual physical tests of those activities. And what they found was the patients said they had recovered and got better, but most of the patients weren't as good as they were before the operation. So we need to think objectively about how we quantify and measure performance after surgery as we move forward. And why is this important? Well, there's a hidden socio-economic cost post-surgery and post-discharge. This Danish study looked at the cost per year of a group of patients who had a hip or a knee replacement. It looked at each year of their health costs, their social care costs, that contributions to national insurance, taxes, etc. This was done in Denmark, where all of their systems are joined up so you can get this data together. And they look at the years before surgery and they looked at the years after surgery. And then they got a reference population from the similar place of living, similar age, mix of males, females, etc., comorbidities. And what they found is in the year of operation, not surprisingly, the patients who had the hip or knee replacement cost society a lot more. But even though they recovered, every year after surgery, they continued to cost society more. So this is telling us that we're not getting patients back to the activity levels we could do. And this is important because most of our patients are in their 60s or 70s. And we know that physical activity is one of the best things we can all do as we get older to prevent illness from a whole range of chronic illnesses and diseases. So how do we address this? When we look at rehabilitation strategies, this paper is a few years old now, but I think the conclusions would still be similar based on the current research. We have a question mark around prehabilitation. It's not required for all patients. It may be required in some set groups, but that research is still lacking. We still don't understand the true mechanisms of decreased muscle function. It can't just be atrophy. There must be some inhibition that's going on. Early strength training is feasible, but the results have been less promising. So we need to define what optimal physiotherapy is, and we need to understand that that may be different for different groups of patients. Different groups of patients may need a different rehabilitation protocol or at a different time after their surgery. One area that's being increasingly looked at is technologies, smartphone applications, activity trackers, Apple Watches, etc., checklists. So what do we currently know about these technologies? Well, wearable technologies are certainly attractive. And in this review a few years ago, we looked at how, if they actually on their own would improve someone's activities after discharge. What's clear is the use of them is feasible. They're increasingly becoming part of our lives. But on their own, there's no evidence to support the efficacy of the wearable device over traditional rehabilitation. Smartphone applications with exercises, videos are also increasingly used. When we looked at this, they were highly variable in quality using the Mars subscales, which is a specially designed tool for analysing patient apps. There was no link to improvement in outcome in any of the studies that we found of these apps. There was a poor link of content to the evidence base, and we couldn't find any of them with evidence that the patient was involved in the design. And this is sad because we're repeating the mistakes that we've been making in our written information for patients. We looked at this study a few years ago when we analysed the written information given to patients before hip and knee replacements in the United Kingdom. Only 40% of them mentioned an enhanced recovery pathway. Just over half of them told the patient they would mobilise on the day after surgery or the day of surgery. And the exercise prescription and instructions within most of the booklets was very poor. So we need to be careful that when we move to these technologies, we don't replicate these poor information that we're currently giving patients. We need to use the opportunity to improve information. And we also need to think about how we deliver it. This is really important. We looked at another analysis of these smartphone apps, and we looked at a readability analysis. And we found that most of them were written at a level which was difficult for patients to comprehend. The use of medical jargon and medical terms. So it's vitally important that we get patients to be involved in the development of these as we move forward. So, in summary, I've talked about the background, the components and the history of enhanced recovery, why it's important and where we've got to with hip and knee replacement. I've linked to the ERAS Society guidelines and highlighted those active components. I've talked about the future, increasing day case and outpatient hip and knee replacement, and also thinking about what happens to the patient after discharge. And there's great scope for improvement and further work here, and embracing technologies in the future so that we can help our patients. Thank you for your attention and good luck with your programme.